When you go to the doctor, they'll take your temperature, they'll take your pulse, they'll take your blood pressure. They want to find out how your body is doing. Well, for public health, the community is the patient. We want to take the pulse of the community.
Texas has Texas-sized challenges, but also Texas-sized opportunities. We have people who have been doing AI and machine learning in healthcare and public health for the last 12, 14 years, well before ChatGPT was our companion.
Welcome to Learning from Leaders, a podcast from Southwestern Medical Foundation where we dive into a world of wisdom, mentorship, and innovation, exploring the insights and life lessons of seasoned community and business leaders. I'm Michael McMahon, President and CEO of Southwestern Medical Foundation. I invite you to subscribe now and join us on this empowering journey of growth and leadership. Now, let's learn from the best and drive meaningful change together.
Welcome back to Learning from Leaders. Today, we're privileged to welcome two renowned public health experts, Dr. Richard Hoffman and Dr. Saad Omer. Dr. Hoffman has dedicated his career to public health. He has worked for the Centers for Disease Control and Prevention and served 15 years as Chief Epidemiologist for the Colorado Department of Public Health, before being appointed as the state's Chief Medical Officer. Thank you for joining us, Dr. Hoffman. And Dr. Saad Omer is the founding dean of the Peter O'Donnell Jr. School of Public Health at UT Southwestern. Prior to coming to UT Southwestern, he was the director of the Yale Institute for Global Health and has conducted studies in the United States, Guatemala, Kenya, Uganda, Ethiopia, India, Pakistan, Bangladesh, South Africa, and Australia. Thank you for being with us, Dr. Omer. All right, so Dr. Hoffman, I'd like to start with a great quote of yours that says, "The thing about public health is, when it's doing its job best, you don't notice it." A lot of people may hear the term public health, especially during the pandemic, but don't fully understand all that it entails. Can you share more with our audience about what public health is and why it's important?
Well, public health is important every single day, and it helps us have clean water, good sewage systems, clean air or improved air quality. It helps us with when we go to restaurants and to essentially trust that the restaurant is practicing good technique in food preparation and that the food that comes to the restaurant is also safe. And then when regards to direct services, vaccinations that prevent diseases like measles, which plagued us and killed many children, rubella, which is also called German measles, and used to cause many birth defects because of pregnant women becoming infected during their pregnancy, and mumps and chickenpox, which we used to just sort of take for granted, but actually has many severe forms, and helped us with tuberculosis, which along with malaria are two of the major killing infectious diseases in the world. And then there's all sorts of chronic diseases that we've been able to expand public health to provide care and guidance for people with high blood pressure, with diabetes, with just a host of chronic diseases. And finally, public health is involved in injury prevention, so that there are airbags in our cars, there are guardrails on our highways. We take all this for granted, but it wasn't there 50 years ago. So those are public health interventions. We don't actually have to do anything to in terms of a behavior. I mean, we do fasten our seatbelts, but otherwise, the airbags help us if there's a crash or prevent a car from rolling off the road. It just is, it's there every single day, and we just don't have to think about it all the time.
Thanks for sharing. Dr. Omer, is there anything else you'd like to add?
Yeah, so same thing. I think it was, Dr. Hoffman described it very well. What attracted me to public health were two key features of public health, but also the attitude public health has as a field. So the two key features are that public health looks at prevention more than cure. So to borrow an example from Dr. Hoffman, we were just talking about this. Public health is like firefighters. You go in, you put out the fire, but also you prevent the fires. You have fire safety. Clinical medicine is like cops. They go after the event has happened, so treatment. But public health is more prevention. So that's the one characteristic that attracted me. The other key feature, which is very helpful, is that it works at the population level, not just at the individual level. It says it's a little bit greedy in terms of having its impact. But beyond that, this emphasis on prevention and and the big impact, it also has a tradition of applying science for improving human lives. And so that condition, so the science of epidemiology, which is a subfield of public health, or looking at human behavior, etc. So a lot of our successes have come from this attitude that wherever it may take us, we will observe what are the risk factors of developing hypertension or high blood pressure. What is the best way of controlling diabetes? How do we increase screening for cancer and actually prevent cancer from occurring rather than treating? And then say, look, we can do it at a population level, and we have had major impact on a lot of lives as a field. And so that's extremely, when you are part of that big tribe that does it, and then that tribe also has the skills to measure the impact, there's nothing more gratifying than that.
Yeah, I would add, when you go to the doctor, generally they're, and you're feeling bad, they'll take your temperature, they'll take your pulse, they'll take your blood pressure. They want to find out how your body is doing. Well, for public health, the community is the patient, not the individual. So to build on what Dr. Omer just said, we want to take the pulse of the community and the temperature. So we find out are there a lot of flu cases resulting in hospitalization for pneumonia? And or is this just a light year, meaning the temperature is normal, or is it really hot? That's a key difference, is the community is the patient, and we don't want to tolerate too much disease. We want to try to prevent disease and lower the numbers of ill people.
Mm-hmm. Well, Dr. Omer kind of shared what drove him into this field. You've had such a storied career in this field, and what drove your passion for it, and why are you still?
Well, I didn't initially know much about public health at all. I went to Southwestern Medical School for my medical training, but after that, I thought I was going to be a regular practicing clinical doctor. But somehow I by fortune, really got connected to the Centers for Disease Control and Prevention back in 1978. And I was an EIS officer, and I just found it so interesting. It was allowed me to get out in the community and investigate. I put on a medical detective hat and to stop cases of plague in New Mexico, or to try to control outbreaks of measles or of hepatitis A. There was a problem with a uranium tailings pond spill in western New Mexico, where people were worried that they were exposed to radiation. There were just a variety of problems, and my task was to investigate and try to control or prevent. And I just found that so interesting. I didn't know anything about what was going on in the community behind the scenes.
Dr. Omer, the new School of Public Health at UT Southwestern has been operating for a little over a year now. How do you see UT Southwestern's role growing as a major player in public health on a local, state, or even national level?
Yeah, I think when I started as the founding dean, I had a really good environment to work with. UT Southwestern emphasizes excellence and invests in excellence. The way we expand UT Southwestern's mission is to say that excellence in and of itself is really helpful in moving things forward, but in public health, we bring it more proximal to impact. And so that's our founding ethos, excellence for impact. And what does that mean? That means that we do the best available public health science. We look at risks of cardiovascular diseases. We evaluate interventions to improve outcomes in diabetes. But we also bring it closer to communities. And so, for example, one of our faculty members coordinates a network of 32 community and faith-based organizations in the DFW area that covers a very big swath of the population. For example, our faculty members are working, both primary and secondary faculty members are working on food as medicine and food security, but in a very evidence-informed way, that it is not just the availability of any kind of food, but food that is healthier, etc. So these kinds of things are what is how the School of Public Health part of UT Southwestern is building on a legacy of excellence and extending it to saying that it's excellence for impact or for proximal impact. And we've been gratified. We have been able to recruit some major leaders in public health to our school. We are already, in a short amount of time, we just a 67th faculty signed on, who's an American who's moving back from Oxford, for example, to Dallas. And then on the other she's on the younger side or early stage side of the spectrum. On the other hand, we just recruited someone from Tulane who was trained at Johns Hopkins and was the chair of their Department of Epidemiology, who's our inaugural chair of epidemiology. So building that school to be impactful, to nurture excellence in research, in teaching. We just met, Dr. Hoffman and I met 4 scholars, who are funded through, the support that Dr. Hoffman provides to our school. And they are some of the smartest people that you would interact with in the sense that they're smart and passionate about getting the best training they can get, but not just as an end to itself, to have impact in terms of various areas like maternal health and child health, like mental health, etc., and so on and so forth.
Well, it seems like the school, after just 1 year, has incredible momentum, and excited to see what the future holds for all the initiatives y'all are pursuing. You also touched on kind of specific ways of trying to make public health impact in communities. And Dr. Hoffman, I'd be curious to hear, how do you compare the community challenges that Texas faces versus where you live in Colorado?
I would try to answer that this way. They're different populations, different composition, so and different climate. So Texas has been unfortunately hit by hurricanes and floods and electrical outages that created some health problems. Colorado has got its own problems with farm injuries. It's to some extent because of modern travel and people going around, we have similar problems. Okay, things can go from one side of the planet or one state to another in a day. But and we have a sort of standard of living in the United States that, has got its share of inequalities, but nevertheless, there's the baseline: food, water, and air. Those things are in common between Dallas and Denver, for example, because it's an American lifestyle. So there's a few differences, but we face similar problems, and we have to coordinate. All of the states do need to coordinate because of this movement of people. And we both, Dallas and Denver, have homeless problems. And we both are trying to figure out what's the best way to deal with it with our given resources at the moment.
And Dr. Omer, you touched on this a bit already, but what do you see as some of the maybe more unique challenges facing North Texas, and how do you hope UT Southwestern can try to address them?
Yeah, absolutely. So not just not Texas, but also Texas overall is impacted by several major risk factors for adverse outcomes in addition to what Dr. Hoffman described. For example, obesity is a major issue. For example, mental health, especially in young people, and related to that, overlapping to that, substance abuse. But there are sort of different factors as well. But that's an emerging issue. Access to health and care, so both clinical care and public health in our rural communities, is an underappreciated issue, even within this field of public health. But when you look at the data, and there are major disparities, there are major differences between outcomes in our rural communities versus urban communities. So these are some of the challenges in terms of disease groups, cancer, cardiovascular diseases. But I will say, if I may take the liberty to say that, yes, Texas has, for lack of a better term, Texas-sized problems or challenges. In public health, we see them as challenges that can be addressed because public health has a history of addressing major challenges, but they don't happen on cruise control. You have to do some stick shift driving and make these efforts to make sure that you bend that arc a little bit. But Texas also has pretty substantial opportunities as well. And that's why we are, as a new school of public health, we believe that we have that recipe for having impact. As I said, it will require a lot of hard work. I'll give you an example. The state, through the UT system, is bringing together data, outcomes data, from all 14 UT system healthcare organizations. One of our early strengths in terms of approaches is health data science at the School of Public Health. We have people who have been doing AI and machine learning in healthcare and public health, who were part of other departments at UT Southwestern, and they were public health scientists, became part of the school for the last 12, 14 years. Well before, ChatGPT was our companion on our phones. So they have been, so these strengths, leveraging the state level investment in bringing together data from all 14 healthcare organizations and setting it up as a platform, provides an opportunity to have an impact on at the mass level. Because you need, in order to study some of these phenomena, in order to see whether interventions work, you need a certain numbers. You can't, you don't have the statistical power to study a lot of these phenomena in smaller populations. So Texas has Texas-sized challenges, but also Texas-sized opportunities. Another, example I would give you is that there is a state-level investment in behavioral health facility. And the new chair of psychiatry, who at UT Southwestern, is a willing and eager partner with the School of Public Health to say that yes, we will have a cluster of patients. We should also focus on prevention. We should also focus on what happens to these patients out in the populations, in the communities. And so UT Southwestern's investments, and another example, the examples are so numerous. Dr. Hoffman and his family has invested in the Dallas Heart Study, which precedes the School of Public Health, which looked at risk factors at the population level, at the individual level, for cardiac outcomes, cardiovascular outcomes, and then now sort of brain health. That provides the infrastructure to go to the next stage with our epidemiologists, with our data scientists, with our behavioral scientists to now look at these risk factors, develop interventions, evaluate those interventions.
I love the framing of the opportunities in Texas being big. Everything's bigger in Texas as a native Texan, and we have pride in that. One, I think, very relevant public health topic that maybe is the elephant in the room we haven't covered yet is the COVID-19 pandemic. And it was a tough time for everyone, but I think as public health experts probably had some very critical lessons learned. And Dr. Hoffman, I'd be curious to hear your perspective on that and what we might be able to learn for future potential crises.
Well, we need leadership at the state and at the national level, and to make sure we're all on the same page. So during COVID, to some extent, each state was on its own. And even within the states, the local agencies were charting their own course. It was a tough time, as you said, because we didn't know very much at all about this particular virus. We didn't know how it was spread, and didn't have a vaccine. You know, we had to rely on traditional methods of isolation and quarantine. That's why we had lockdowns. We had to rely on hygiene, which means washing your hands. There was a lot of instruction about washing your hands and covering your nose and mouth with mask or whenever you sneezed or coughed, because that could spread. We didn't know how close, people needed, and for how long, what constituted a significant exposure to the virus. So there was a lot of talk during COVID about we have to apply science, but the problem is it was a new disease, and so it wasn't easy to figure out the science. And all right, that was one part of it. The public might have had an expectation that these experts knew everything immediately, when in fact they didn't. But another lesson, I believe, from COVID was the need for coordination. So there were three groups broadly. Public health, which normally is responsible for controlling outbreaks of infectious diseases. And then you got the healthcare system, which was dealing with the sick individuals. And then you have the pharmaceutical system, which was trying to develop vaccines and antiviral pills or agents. And it needed a lot of coordination, and it was tough at the very beginning, that's for sure. And to do all that, you have to instill some trust in government leadership, because they're the ones who are trying to coordinate this. And I don't exactly know how to explain it, but that trust was lacking. I'll put it like that. And I think that did not help matters. You have to have, when I say trust, I mean you have to have somebody in front of the cameras who's known to the public from past experience in the cameras and explaining things. And I don't think there was enough trust in the leadership there. So that that wasn't helpful, I'll put it like that, at all. So those are some of the problems.
That makes sense. And we all know about the big challenges and problems, but in context, there are some impressive things that happened in terms of our response, and it might have taken a little longer than people hoped, but the ability to diagnose cases with technologies like PCR, and then eventually roll out the new vaccines with a new mRNA vaccine technology, were pretty monumental breakthroughs, but that was founded on decades of research. And Dr. Omer, I'd be curious to hear your perspective, or maybe you could enlighten the audience a bit on what it took to be ready to respond like that.
You are absolutely right in terms of asking these questions, and how do we be ready for what it took, and how we be ready. I'll actually come to that. But one of the things that I would expand on, the trust in public health has the communications aspects as well. But in addition to that, sociologists have actually looked at it. And so there is, if the population believes that whatever entity, public health or other entity, is free of conflict of interest or has their best interest at heart, they perceive them to be trustworthy. But there is another important element to it, which public health and others have some agency over, which is perceived effectiveness and competence. And that's a way into earning back the public's trust, is to deliver for the public. Next time this happens, we shouldn't have a 4-month delay for our premier public health agency to come up with testing. So that's, again, you have to confront these things in terms of the things that could be done better. We were flying blind, as a country. It's a fair question to ask. If individual labs, so I was in New Haven, Connecticut at Yale at that time, when one of our lab colleagues, using specimens of the study that we collaboratively set up from patients who were walking through our door, so that those specimens can be tested. If they could come up with the test in mid-March, why could CDC? And then we weren't the only option. We were not the only medical center where our colleagues, lab-based colleagues, did that. There were other medical centers that did that. So why couldn't we do it at the public health agency level? So there was these kinds of things, and turns out it wasn't a shortcoming in science. It was shortcoming in management, and it's shortcoming in scaling up. So confronting that head on with some sober reflection is important. Coming back to your other question, so how did that happen? I have a perspective from our microcosm. I'll give you an example. At the beginning of the pandemic, in March 2020, a few of us gathered, immunologists, virologists, epidemiologists like myself, and we gathered around and when we started working on the pandemic-related scientific questions. And one of the things, one of the data points from as early as January, we started actually coming together in February, but one data point from very early on was that the viral RNA was detectable in the feces. Some of us kind of got concerned because SARS-1 in early 2000s actually had a fecal route of transmission as one of the routes of transmissions, that although it was a respiratory illness, it had this roundabout way of causing sort of apartment level outbreaks in East Asia of SARS-1, to those of you who remember. But some of us are eternal optimists, and those of us who had worked on polio in other continents potentially saw an opportunity. So if the viral RNA was there, even if it's not a mode of transmission, if it's a mode of transmission, we should, look at it and, study it and then try to prevent it through that route. Even if it weren't, it could be an opportunity to detect it and in the sewage without relying on a lot of human factor. And so we gathered together, and as an example of, again, staying at your question, how do we prepare? I was leading the Yale Institute for Global Health, and a bunch of us reached across different schools and institutes and centers. So 6, 7 of Yale's entity got together, ranging from the medical school, the School of Public Health, to the School of Engineering. And we said, can we bring together a group of mathematical modelers, environmental scientists, engineers to start detecting this in wastewater? The viral RNA, even if it's not alive, can we start doing that? And the question was, how do we do it? So in the middle of the first shelter in place, our med students, our engineering students went down manholes in front of the Penn Station where the trains from New York would come in New Haven, Connecticut. And we would collect specimens from the water testing, wastewater testing facility and all of that. It turns out, but we not only want to detect it, we wanted to see, could it be done? Could we do some epidemiology to say, can it predict the outbreak? So that was the key. So we were scooped by a group in Boston. We probably identified it, like one of our collaborators in part of that group identified it in the sewage, wastewater, before the Boston group. But if you didn't publish it before, it didn't happen. So that's the rule. So the group, a private entity in Boston, shared their results first in terms of identifying it, but we were the first group to share that you can actually not only use this to identify, but it can predict. It gives you a head start of 3 to 7 days, depending on whether you're looking at community-based rates or hospitalization rates. And it's like almost like starlight. So this is one example, and the key lessons was that whether we were exceptionally intelligent or gifted. No. It was that we came together in terms of various disciplines coming together, number one. The second thing is just doing this from a perspective of overcoming some of the challenges. And so that's what the ethos we are trying to bring in here, to be consequentialists, to look at the outcomes first and then recruit disciplines in the service of specific public health outcomes. So this is how we as a country, as a world, prepare for it, learn hard-nosed lessons, and ask the questions as it is that why did we have gaps in understanding of transmission of a coronavirus when we understand a lot more about flu transmission? So we do research now. We're collaborating with our local health department to look at the home-based effectiveness of air purifiers in reducing viral transmission in Dallas. So this is in nascent stages. This was a project that we are planning in very initial stages of planning, that we test out commercial air purifiers or homemade air purifiers where you bring together HEPA filters that, you have that, put a fan around it, literally through duct tape, but you have a manual that you can transmit to families and they can do it themselves. And the third comparison group will be, just what the families are doing. Then we will do viral testing in each of these groups. So this is what public health is about. When it's even out of the news, we as public health people have to generate the best available evidence, because when the next one comes around, that evidence will come in handy.
Dr. Omer's making me, bringing back some memories, but in my career. But the COVID pandemic was very scary at the beginning. We were all looking at images or had family members who were dying. It was a scary time, and people, when they're that scared, and it's that universal, pretty much, at least in terms of the application of the shelter-in-place lockdowns and that sort of thing. Everybody's affected, but things moved very fast. Maybe not fast enough as we would like, but from seeing the virus for the first time in the U.S. in January of 2020. And having a vaccine in December of 2020, at the end of December. That's the fastest on record that a vaccine has been developed. And yes, we needed the tests faster. But I just want to remind people that we saw the first cases of AIDS in 1981 in New York and in Los Angeles and San Francisco. We didn't have a test for HIV, the virus that causes AIDS, until about 1985. Okay, it took 4 years. We didn't have a treatment for HIV or AIDS, the first one, which wasn't that effective until about 87 to 88. Things were much slower back then. We had treatments for coronavirus, within, I don't know exactly when Paxlovid was licensed and on the market, but there was some initial, but probably about a year. Things moved faster, but the whole society moves faster too because of 24/7 news coverage and multiple sources of that people can go to learn what's going on, what the news is. Whereas you go back 40 years to HIV and AIDS, and it was, the evening news or the newspapers where people learned about things. So our society is moving a lot faster, but we responded pretty fast to COVID, just not to everyone's satisfaction because of so much fear.
Right. You brought up a really interesting comparison between the HIV/AIDS epidemic and COVID, and I'd be curious because HIV/AIDS, obviously there are treatments for it, but there's not really, I know there's some in testing, but there's not any effective vaccines yet that are on the market. Do you think that the technology lessons learned from COVID with vaccine technology or other treatment modalities could be translated to areas like HIV or maybe other really tough global diseases like malaria or tuberculosis?
Well, certainly, but Dr. Omer's a vaccine specialist, so I will defer to him for the response to that.
Yeah, I agree. So there are prospects. I would, in HIV, it's not just the virus, it's also how the host reacts to it is a challenge. But some of the other ones have other diseases that require better vaccines. So malaria has a really good vaccine that is deployed in Africa, which will save and has shown to, even in early stages, is shown to save a lot of lives. But we could do better. So the next generation of malaria vaccines could use some of these newer technologies. The next generation of TB vaccines, tuberculosis is a major killer around the world. The other thing that we should prioritize is what we call a universal influenza vaccine, a one and done shot. If there is a moon shot that we should strive for, because our hospitals get overflowed. I was visiting, every year I was at Parkland with my colleague and someone, who I have come to know since moving to Dallas, their CEO, Fred Cerise, and their Parkland Hospital is overflowing, and this seasonality has a real impact of admissions through influenza and pneumonia, because what often happens is there's a 1-2 punch of a virus predisposing you to a bacterial infection and that causing pneumonia. We have known that since the flu pandemic of 1918, that there is that kind of a relationship, initially at the syndromic disease level, but then they figured out that this pathogen interaction, virus-bacterial interaction. So if we have a universal vaccine that goes after the parts of the flu virus that do not change, that are more stable, and some of these new technologies can be promising in that direction. And so a lot of these things that have come out of these adversities are very helpful. If there is a silver lining, and again, public health is full of optimists, and if there is a silver lining, it is that some of these things, and not just in terms of biotechnology, but in terms of public health interventions, etc., that show promise. So some of home-based testing, saliva-based testing that was actually developed by public health people rather than basic scientists a lot of these tests. And so those have implications well beyond coronavirus and COVID, etc.
Yeah, I want to add another positive thing that came out of the COVID, sort of positive and negative. There was a lot of burnout in the public health professionals. A lot of people left the public health departments, and some in the hospitals as well. And so a positive is the development of the School of Public Health, which is going to help us replenish the supply of professionals for, Texas, Northeast Texas, and bring some new minds, new energy, and help us in the future.
Definitely. Switching gears a little bit, Dr. Omer, you touched on this actually a couple of times, setting an ethos for the new school, and I'd be curious, kind of on that line, what are kind of some of the leadership traits and leadership tactics and skills that you all try to implement in leading the teams that you have over the years and currently?
Well, we want smart, hard workers, okay, and dedicated people. And because things happen around the clock, not just between 8 and 5. And it's a team. So we have to have teams of people with different skill levels. Some are better at, those teams are composed of local people and then more specialized experts. The local people know what their community needs. They know who the people to contact are in the local area, and but they don't necessarily know the specifics of COVID or whatever disease we're dealing with. Mpox as another example recently. So. That's what I would be looking for, is replenishing and strengthening those teams that can feed off of one another to accomplish the task that is to protect the public.
Yeah. In terms of what we are doing at the school, and the reason for, you alluded to our founding ethos, excellence for impact, and the reasons why it has emphasis, dual emphasis, both on proximal impact and excellence, is that our communities, our populations, those that are served by public health, deserve our A game. So therefore, we emphasize in our school the quality of instruction, the quality of mentorship they receive from their professors, who are some of the top researchers in public health. But also there is an applied component which takes them to communities, that takes them to health departments. So there's this dual focus, is in service of a mission that the way we serve is through sheer competence and training. In terms of the content of that training, beyond the quality, so we have the disciplines, both quantitative and qualitative disciplines, that help them interpret large amounts of data quickly, that helps them engage with communities. So we give them tools, we front load those skills in our curriculum. Ours is more sort of skills-based curriculum on the education side. We also emphasize management, because a lot of times if you're doing applied public health, you're managing groups, working in teams, as Dr. Hoffman mentioned. You have these emotional intelligence related skills. You have to know how to project your budgets that are sort of that go through these boom bust cycles. And so that is part of not just our curriculum, that is emphasized as part of folks who teach them, are the ones who are sometimes in leadership positions themselves, etc. So making it comprehensive. And then in their second years, for example, for our master's program, there's further specializations, but these core skills include quantitative and qualitative skills to assess data, engage with communities, but also manage teams, populations, etc., and all of that stuff. So that's a deliberate emphasis to make sure that we are creating a workforce that is ready to deliver and brings their A game to the service of public health.
I would just add one little anecdote, which I gave a talk at the school yesterday, but I didn't include a slide that I wished I had included. But there's one disease on the planet that has been eradicated, and that is smallpox. And the eradication started in 1966 and ended with the last case of in 1977. And it was led by two Americans, D.A. Henderson and Bill Foege. Bill Foege went on to become the director of the CDC, and D.A. Henderson went on to become the dean of Johns Hopkins School of Public Health, amongst other things. But Dr. Foege wrote a book about how smallpox was eradicated. And he said that the problem wasn't so much medical or scientific, it was management. Just exactly what Dr. Omer was saying there. You've got to manage things properly to be the most competent to take advantage of your resources. You don't have unlimited resources, so that's what management is helping you do. Send out the troops, the teams, and use your limited resources most effectively.
So I don't think you know this, Dr. Hoffman, since you brought up Dr.
Foege.
My first endowed professorship that I had the pleasure of holding was the Bill Foege professorship.
Oh.
And I remain a fan of Dr. Foege. He is in his late 80s, is still very much contributing to public health. In fact, during mid 2020, the National Academy of Medicine, and I ended up becoming a member of the ended up being inducted into the National Academy of Medicine subsequently. The National Academy of Medicine was asked the question, even before the vaccine became available, what should be the science-based priority and science and ethics-based priority for who gets the vaccine first, second. And the group that was established by the National Academy of Medicine was co-led by Dr. Bill Foege, and I had the privilege of serving in that group. So it was an experience of a lifetime to be in the middle of a pandemic, to work with ethicists, work with scientists, to contribute both science and looking at emerging data, to say that it wasn't a given, to be very honest, that older people should get it first. That was there were other reasonable sounding arguments at that time before we 100% understood the disease itself. Turns out a lot of that deliberation, especially the first, we then looked back and said that how that prioritization worked in practice. The first couple of groups were followed by all states, and after that, the vaccine became so available that it was opened up to everyone. But that deliberation with someone like Dr. Foege was again a privilege. Coming back to building on this example of smallpox, the U.S. had relatively low level of investment and was the biggest investor in smallpox eradication. Because this disease caused so much mortality, so much death and disease, it turns out it's not just helpful to eradicate that disease from around the world for the sake of vulnerable populations in Africa or Asia or Latin America. We directly, as a country, benefit from that eradication effort, so much so that according to economists who do cost out these things for a living, the U.S. breaks even on its investment every 29 to 30 days. Talk about a return on investment, because we can afford not to worry about one of the most consequential killers. And so that's the ambition. That's the ambition to say that we address problems that look unsurmountable with a level of ambition and audacity, but by bringing in the tools, by preparing the generations, both in terms of research but also education, so that they can encountered these problems with some success.
Well, those stories about smallpox and the connection with Dr. Faggy are amazing. And in order to become a leader in a field like this, everyone needs a mentor to become a leader. And it sounds like perhaps Dr. Faggy might have been one of those for you all. But are there any other mentors that stand out for you in your career?
There were two for me. One was my first boss, mentor, when I first began public health epidemiology. That was a gentleman named Jonathan Mann. He was a physician, and I was working in New Mexico, and he was my supervisor. He was the head epidemiologist for New Mexico. I was his assistant. The other was a guy named Dr. Tom Vernon, who was the health department director in Colorado, where I first started working. He just showed me leadership and calmness and stability and clear thinking. He knew public health backwards and forwards. Both Dr. Mann and Dr. Vernon were able to talk to the public and create trust with the public. So those are the two principal mentors I had. Dr. Vernon, after he left the Colorado Health Department, went to Merck and worked in their vaccine division, preparing vaccines. And his task was to essentially explain how the vaccine worked, how it was safe and effective.
Dr. Omer?
So it's how almost it's so interesting how life sometimes works. So I did my medical degree from Pakistan, from the Aga Khan University in Pakistan, and then I did my public health training, both master's and PhD, at Johns Hopkins in Baltimore. My earliest mentor in a group mentor setting, a small group mentor setting, was a UT Southwestern graduate, Dr. Steve Luby, who went to Pakistan as a young, fresh graduate from the Epidemiologic Intelligence Service program from the CDC. He was recruited by Dr. Joe McCormick, who for the last 20 years has been in Brownsville, close to the border, leading a public health program there. And so Dr. Steve Luby inspired me to do epidemiology, to do public health, one of the factors. And then I came to Baltimore, and my mentor was a pediatrician and epidemiologist called Dr. Neil Halsey. And Neil is still in Maryland. He's now a professor emeritus. And the fact that he was so inspirational, he is a no-nonsense person and emphasized excellence above everything else as a way of serving the populations you are serving. And again, almost like, if it weren't real, it would be too on the nose for any Hollywood writer to write that script. One of his mentees, one of his younger mentees was an overachiever who arrived in Baltimore in her truck from UT Austin. She, I was a faculty member by that time. She was a student. Turns out, she ended up at UT Southwestern as a faculty member in cardiology. And she was the one who actually nudged me to apply and to come to Texas and look at this position as the founding dean of UT Southwestern Peter O'Donnell Jr. School of Public Health. So this arc of mentorship and mentees coming together and this sort of Texas connection, it's almost as if, of course, there are these probabilities in the universe and all of that stuff.
Predestined,
that's the word. So it's a little bit, interesting arc as far as I'm concerned, since you asked about my mentorship. And I've been privileged. And one of my goals is to, and one of the reasons why I am so proud to be part of a school of public health is it's twofold. First of all, one of the easiest investment a professional can do is to invest in the next generation of professionals. So that's the purpose of higher education. Therefore, I continue to teach. Like, I'm not an administrator, in the sense that 100% dean. I am a professor as well. In fact, I have a class this afternoon. One of my colleagues from Michigan is doing a guest lecture there, and who I introduced, by the way, to Texas barbecue last night in Deep Ellum. And I think he's a convert now to Texas style of barbecue. One thing is to do that in terms of any profession, but in public health, when you invest in the next generation, you have that double benefit of impacting lives through training and mentoring. And one of the proudest things in my career is that now my mentees, early mentees, have started taking up their leadership positions. For example, one of my mentees took up as the chief of pediatric infectious diseases at Yale. Another one is creating a brand new program in Doctor of Public Health at Emory University in Atlanta. A third one I cannot disclose is being considered for a leadership position. So since this is privileged information on his part, and I would be the one who would be the most proud of that achievement. So it's a privilege to be able to do that, and the privilege to be able to do in a state and in a region where there's opportunity for impact. So, for example, we just, in the nascent stages of creating a collaboration with 3 health departments. We did it for an invitation based on a grant invitation from the state health department. We brought together 3 health departments in the area, Dallas County, Denton, and Tarrant. And I was saying that collaboration, that population covered by just these counties is higher than 33 states in this country. And to train people to have impact in this region, but also we are training people to have impact in Texas, beyond DFW, and nationally. That's a privilege. And that's an extension of the only way to look, we can be worthy of the serendipity of finding good mentors. It's almost serendipitous. Like you show up at your job at the health department, leadership is stellar. You show up at Johns Hopkins and your professor and your boss is one of the leaders in the field. So how do we become worthy of that serendipity? It's only in retrospect. And in retrospect, in a way, is that how we pay forward as mentors, in my case as professors, and in some cases as deans.
I earned a Master's of Public Health degree from Johns Hopkins, but when I went there, I received a scholarship, and I was grateful for that scholarship. And so today, that was back in the 1980s. Today, I am help this new school of public health at Southwestern by endowing a scholarship program for students. And I did that because I think investing in education for the next generation is the best investment. And we were fortunate that this morning I was able to meet some of the 4 of the students at the school who have received scholarships. They're excellent people. We can rest assured the next generation is going to help us, going to protect us. And so I'm thrilled to be able to contribute in that way through the scholarship program, just the way I was grateful for my scholarship.
Yeah, the impact of education is so powerful. And you beat me to the chase. I was going to ask about your philanthropic efforts here at UT Southwestern. And I think the foundation and the community is so grateful for you paying it forward, as Dr. Omer talked on. So as we look to the future of public health, we've been pulling on these strings a bit through the conversation, but what are maybe some future technologies, perhaps everyone's mind is on AI. And you mentioned how AI and machine learning have been being used for over a decade in your field, but how could things improve and change in this field?
I'll step in just for a second. You mentioned AI, but there's other ways to change. These new RNA vaccines are one, but I want to just step back 10 to 15 years and just say that over that period of time, we've had in this country a lot of deaths from drug overdose, from fentanyl and things like that. 10 or 15 years ago, we did not have the availability of naloxone, which can save a life. And that is a medicine you give somebody who's overdosed. You think it's from fentanyl or some other opioid, and it will restore their breathing. It will reverse the effects of that drug and save their life, and hopefully they can get into substance abuse treatment. The way that we administer naloxone, first of all, it used to be prescription only. It was only really in emergency rooms. Now it's out there for the general public. It used to be administered, I think, IV or intramuscular. Now it's available in something that a person, a helper or supporter, can administer through the nose, okay, through a spray. So there's some technology there that is helping us save lives. It's not primary prevention. They were a drug user and they overdosed, but it is secondary prevention, meaning we've saved a life right there on the spot, and that's an important technology development.
Yeah, I agree, and we need to focus on it from primary prevention, meaning reducing substance abuse. Then secondary prevention, where we make sure that the access is there at the right place, and then tertiary prevention in certain cases where we miss those, where we reduce the impact of it. Coming back to your AI and sort of technology focused question, yes, the next application that is waiting to happen is improving our disease surveillance capabilities through AI, because we should have shorter reaction times to the emergence of outbreaks. So it's not just a new outbreak of a new pandemic flu strain, etc. It's just the regular stuff where things are aberrant and where to intervene almost preemptively. So have a kind of a weather forecast for epidemics is a use case for the application of AI to prevent population level outcomes. The optimal distribution of resources for impact, including screening resources, cancer screening, where to place and where to locate, where to send vans. The other part of it, which is AI, but also the use of technology, I alluded to one big gaps in our health system and public health is rural health. And we have to have new models of remote healthcare, so it could go through telehealth, but also non-physician health workers going to homes for certain kinds of interventions, working with the physician somewhere. So it is both technology and application, and in many parts of the world it has been successful through this kind of a combination. We need to do that here, not just in Texas, but rural disparities exist in many parts of the country. So you would assume it would be, for a Texas or California or even a Georgia side state. For some outcomes, rural disparities are in states like Rhode Island, for example, where half sometimes joke half of the state is occupied by Taylor Swift's Newport home. It's so tiny, nothing against Miss Swift's home size, but even smaller states, for some outcomes, face urban-rural disparities. And so the use of technology is the opportunity waiting to be, but there are barriers to it, and these barriers are solvable, and there are public health tools that need to be applied for some of these kinds of interventions. One gap is that while there is federal funding for certain kinds of disparities, there is an investment from NIH for there are certain mechanisms for rural health, but it's not nearly sufficient for the kind of innovation that is needed in, for example, this rural health sphere.
Yeah, well, sounds like obviously still challenges to overcome and work to be done, but exciting ways that technology could continue to improve outcomes. I think to close, we wanted to finish with some more fun and rapid fire questions and do a rapid fire segment. So I'm going to ask a series of questions, and if you can just say the first thing that comes to your mind. So first, what's the last TV show or movie that you binge watched, Dr. Omer?
Lincoln Lawyer.
Well, I'm thinking of a book that I'm reading right now.
That's fair.
Which is a Stephen King book called 11/22/63. I was in Dallas in school on November 22nd, 1963, and on that day when Kennedy was assassinated. But this book is very interesting. I've really never read anything by Stephen King before, and this is about somebody going back in time to try to prevent the assassination.
Which famous scientist, past or present, would you love to have dinner with? Maybe we'll start with you, Dr. Hoffman.
Well, I've met Dr. Faggy on numerous times, but he's always, as a lecturer or in person, just through conversation, is always excellent to talk to. And so I'm going to put him, at least for this purpose, at the top of the list. My mentor, Jonathan Mann, unfortunately passed away in an airplane crash in 1999, but I would love to be able to talk to him again and see what he thinks about the state of public health in the world.
Jon Snow, not the one in Game of Thrones, not the one that, winter is coming, Jon Snow kind of guy. So Jon Snow was an epidemiologist. He was an epidemiologist in a sense that in the 1900s, in the mid 18-something, there was this recurrent pattern of cholera outbreaks in London, and there was this particularly severe cholera outbreak. So he figured out this, now in retrospect, pretty straightforward approach and this is before discovering the cause of cholera, before any biology work was done. So he plotted those rates by location and figured out that at the center, if you will, geographic center of it was a hand pump, and removed that hand pump and stopped that very intractable cholera outbreak. So I would love to go there. And so there is a pub called the Jon Snow Pub in London, and for every epidemiologist and most public health people, it's almost a rite of passage. Everyone has a photo. There. Yeah, I have my photo at the sign that indicates where the Broad Street pump. It was on Broad Street, and in London. So I would love to have dinner with Jon Snow, but I will make sure that it's cholera free. With food safety precautions, I'd love to have dinner with him.
What's a place on your travel bucket list that you haven't visited yet?
I would like to go to see the Dolomite Mountains in northeastern Italy.
Amazing.
I want to go to Antarctica, but it's the Drake's Passage, so that makes me nervous. So there's this part of ocean from the southern tip of South America to Antarctica. You can fly there, but there are no regular flights. But most people who go for non-scientific reason, my science doesn't overlap with the kind of science that happens there. That gives me a little bit of pause. I don't get seasick usually, but it's rough. One of the roughest patches. So yeah, that's on my bucket list that I'll be able to go to Antarctica.
Awesome. And last question, what's one surprising fact about yourself that your colleagues might not know?
I don't think too many of my colleagues know that I'm a vegetarian and have been for over 50 years. So they probably, if we have a meal together, they probably would notice it at that point, but otherwise I don't advertise it or try to convert anybody.
I don't know. So maybe my interest in theater, when I was younger, I was part of a theater group where I was their sort of resident director. So that's how.
I would add on myself that I don't sell my watercolor paintings, so most people don't even see them or know that about me, but it's sort of a private way of keeping a journal of my thoughts.
Awesome. Well, Dr. Omer and Dr. Hoffman, thank you so much for an excellent conversation, and we're so grateful for your leadership and decades of leadership in public health, and the impact you're going to have on future generations, both in terms of public health and the mentees that you train. So anyways, thanks again.
Thank you.
So to learn more about Dr. Omer and Dr. Hoffman, check out the description in this podcast, and also subscribe and follow along for future episodes and lessons from leadership. And we'll see you next time on the Learning from Leaders podcast.
Thanks for listening to Learning from Leaders. If you enjoyed this episode, we invite you to subscribe now for monthly episode drops so that you can continue to learn from experienced business and community leaders to help you drive meaningful change in your community.